Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. This podcast is the second in a series of 3 episodes on bloodstream infections, recorded from a live symposium. In this episode, we hear from Dr. Jose Alexander, who's medical and public health microbiologist at Advent Health in Orlando. He'll discuss how to use rapid testing to inform antibiotic selection for gram-negative bloodstream infections. To listen to the other episodes or to follow along with the slides, visit the show notes. Now let's get started with Dr. Alexander.
When we talk about antimicrobial stewardship for bloodstream infection and laboratory diagnostic, let's see that antimicrobial optimization in 2 different ways, escalation and de-escalation, what opportunity we have. And the implementation of these technologies is always beneficial, or you can obtain the most benefit if you have an antimicrobial stewardship program that is able to intervene. If you have this technology in the laboratory, you don't have a communication pathway, and you don't have protocols to what to do with those results, literally just wasting money. So these tests are expensive, but these tests can actually have an impact if they are utilized in the best way possible. So the idea is that what we can do and how can we implement the rapid AST. Now, if there is a spot for rapid PCR, and let's just call it BCID as we know the rapid PCR done in blood. So can we implement both of them, or we have to implement one, only one? So before I start, it's important to put in perspective antimicrobial resistance. So Enterobacterales is the most typical gram-negative that we isolate in the group that we isolate in the laboratory. E. coli is the most predominant one. So based on the data for our institution, we know E. coli is the main organism. In dividing the Enterobacterales group in E. coli, Klebsiella, and Proteus versus the Spice-M group make a lot of sense for the perspective of what we're looking for and what we can do with them. So we see the E. coli, Klebsiella, and Proteus, that what we consider wild types to be susceptible to 3rd generation, 4th generation cephalosporin, and carbapenems. There is a caveat with imipenem and Proteus mirabilis, and that it could be resistant by porting restriction, not necessarily because there is a carbapenemase. And that is an important consideration with that particular organism. In the group of the Spice-M, they carry an intrinsic MC, that is a cephalosporinase. Could be or not susceptible to 3rd generation cephalosporin, should be susceptible to 4th generation cephalosporin, and susceptible to carbapenems. So that in the same group of the Spice-M, there is some of those organisms that have a high risk of expressing MC quickly. And those are the ones that we need to make sure that the narrow spectrum that we use on them is cefepime if there is no any other resistant mechanism involved. Having this in the perspective is critical to be able to know how this technology, the BCID and rapid AST, is going to fit into the equation to provide the patient with a proper escalation or a de-escalation of treatment. Antimicrobial resistance is multifactorial. But one advantage that we have right now with the Enterobacterales group is that most of the beta-lactam resistance is very well defined based on beta-lactamases. We have ESBL, that is, CTXM is the most predominant gene circulating and can be identified using rapid BCID. We have a group of carbapenemases gene that can also be identified. We know that we have other mechanisms that we cannot, like porting restriction, efflux pump, play a significant role. And at this point, it's important to have also in perspective, there is this other group of gram-negative that are the non-fermenters, Pseudomonas, Acinetobacter. That group is very difficult or almost impossible to define phenotypically based on a BCID because they have persistent mechanism that we don't have a gene-specific target in the BCID, or the mechanism is mediated by mechanism that we cannot identify by PCR. So like porting restriction in Pseudomonas aeruginosa producing a carbapenem-resistant Pseudomonas. The only way for us to be able to see that is having a full phenotypic profile of that organism. So rapid AST play a significant role for non-fermenters because you can have access to a full phenotypic profile that is accurate and more reliable than using only BCID. A patient was admitted in day 0 due to a complicated UTI. Patient was in stable condition, elevated procalcitonin and white blood cells. The initial UA was positive with ongoing urine culture. Patient started meropenem and vancomycin, and the positive blood culture showed up in 24 hours of incubation. Take the E. coli, no gene detected. So to be able to use all those criteria, it's important for the facility to have a very well-defined cumulative antimicrobial data. So if you can use those genes, how an E. coli that is ESBL compare with an E. coli that is not ESBL? How that E. coli compare with an E. coli KPC, for example? So defining those antimicrobial resistance and profile can help the antimicrobial stewardship team to be able to escalate or de-escalate based on the presence or absence of those genes. And in this particular case, in day 2, the patient was responding well at treatment, normal renal function, no fever, white blood cell was improving, and the E. coli was confirmed in the urine culture using MALDI-TOF. So we know other clinical information, and in a very simplified way, would you de-escalate meropenem based on the rapid diagnostic, in this case, the BCID, since the E. coli didn't have any gene detected? You continue with meropenem or you de-escalate from meropenem? So the de-escalation and escalation is critical, right? But you need to understand the epidemiology of the gene that you have circulating. In our facility, we were able to determine that ESBL in blood is 97% CTXM. So we still have 3% that are not CTXM. So a risk assessment of the patient condition, the clinical condition, the multi-drug resistant assessment is critical for this type of decision. So we have multiple rapid diagnostic tests, PCR, in clinical use currently. I always say that depending on the situation, depending on the condition that you have, we have like the BioFire, the film array, 33 different organisms, the detection of resistant genes have around 1 hour turnaround time. We have the Cepheid that is specifically for gram-positive coxine cluster to define MRSA for MSSA. We have the EPLEX that used to be the GenMark, now is the Roche EPLEX. They have organism also beyond pathogen that can be identified as a contaminant. They can help to the escalation. The famous Luminex Verigene, battle horse that I don't know if it's still around. Some people using MALDI-TOF with a specific protocol to be able to identify directly from blood. Some fish technology and the T2 biosystem that was actually based from direct blood, no actually a positive blood culture. But in definitive, the important thing is there is still facilities across the US that don't use BCID. And this is kind of mind-blowing that we have this amazing technology to be able to optimize treatment based on organism identification and with good cumulative data to antimicrobial resistant genes, and still are not in use. So what is important of the resistant markers? Well, the rapid diagnostic can actually shorten the time to appropriate therapy for escalation. And this is one of the critical aspects. So a gram-positive cocci, gram-negative rod that we identify in our facility with resistant genes, we know that CTXM and Enterobacterales, we have 100% susceptibility to meropenem because we define the organism as ESBL versus CRE. We haven't found, or at least up to this point, I think we just found the first, non-carbapenemase produces CRE. And that's an important aspect because now we start seeing those organisms circulating when the BCID may fail because there is no specific carbapenemase gene. So we have, when we have a KPC, meropenem valbobactam is a drug of choice. When we have a metallobetalactamase and Enterobacterales, ceftazidime avibactam plus meropenem plus aztreonam is a drug of choice. And we have an OXA48. So the current dynamic of this epidemiology of metallobetalactamase and KPC is changing in the US. So identification of the gene is critical. And this is one of the advantages of the BCID. So from the perspective of the implementation that we are right now in the process, the detection of a gene based on the BCID is enough for us to escalate since we know the profile of those particular resistant mechanisms. Do we need a fast AST in this case? In our facility, no, in the case of Enterobacterales, but we need it in the case of the non-fermenters. But there is benefit and limitation. So the benefit allow for early optimization of antimicrobial therapy, so we can escalate quickly. There is, I don't see any situation when a patient will come to the hospital and we're going to put the patient in meropenem valbobactam empirically, right? So a patient that have a carbapenemase is by default in drug-bug mismatch. So an escalation as soon as possible is critical. Reduce mortality if you use with antimicrobial stewardship oversight. Associated with decreased hospital length of stay is used with the antimicrobial stewardship program because we need that communication. In our facility with EPIC, we have an in-basket. Every time that result automatically trigger to antimicrobial stewardship team, and they're able to do the intervention. But there is limitation. Supplement, but cannot replace the full phenotypic AST. There is always variation of those resistance. And knowing the risk and the difference of that variation is critical. So knowing your data is important. Not all genetic markers or resistant are included. If we look for pouring restriction, efflux pump or some obscure beta-lactamases will not be there. Enable to detect resistance caused by pourings. specifically non-fermenter, is a very difficult. If you find a bean Pseudomonas, there is a carbapenems. But you don't find a bean Pseudomonas, that doesn't mean that Pseudomonas could be a carbapenems resistant. And genetic markers are unreliable for the non-fermenters group. This is how the blood culture look in a standard process. We have a positive blood culture that could be positive from 1 to 5 days. We have a gram stain, we report to the floor. We do a BCI, we plating that blood, and we wait for maybe 16, 24 hours. Now we have the blood, the growth, we have the organism we are able to identify, and then we have to wait 16, 24 more hours to have an antimicrobial, and it's when we do optimization. If we do BCID, we can optimize based on organism and genetic profile, but a full optimization is done down the road of 48 hours with optimization, antimicrobial optimization. So this is the standard workflow, but with the access now to rapid phenotypic AST, we can actually reduce that, and not necessarily for escalation, but now we can optimize the escalation or have a better profile for non-fermenters. We have multiple platforms that are being used, and this platform, they use different techniques. So technically, the blood, the positive blood culture that is set, the instrument have a different approaches to be able to detect. Some of them use the morphokinetic cellular analysis based on fish technology, microfluid or resonant frequency to evaluate the mass and the amount of organism. We have some broad microdilution that use microscopy, like the Q-linea. We have the Celux that evaluate also the viability for fluorescence. And we have the Vitek reveal that broad microdilution that evaluate based on the volatility of some metabolism. So technically, it's evaluating the metabolism of the organism in the well, if the organism is growing or is not, and that it directly correlate with the activity of the antimicrobial. The other significant aspect is where you get the ID. So one of the advantages of this new system is that they don't have an ID required, like in the case of the acetylphenol, that based on the FDA approval, you need to have an ID performed by the same instrument. In this, you can bring the ID from other instrument, like a BCID, for example, a PCR. And if you see the average turnaround time, all of them are within 7 hours. So that's a significant improvement versus 46 hours or 50 hours that we currently have with the traditional phenotypic testing. This can allow your team to be able to have a reliable, full phenotypical profile for the escalation of unusual organisms. So this is how this is how we are foreseeing the implementation in our facility. So we have a blood culture that turn positive, we do a gram stain, we do a BCID, we have the organism ID, we set up the rapid AST, and we are expecting to have an 8 to 10 hours optimization of therapy. So we are reducing between 36 and 40 hours. Now, do we need data to see how this translates to clinical outcome? Sure, but every facility is different. If you look for a small community hospital, without the same resources from a big academic center, you will have a completely different outcome. You will have different impact. But just by a rational approach, if you as a pharmacy, as an infection disease physician, are able to get a full AST for your patient that have a bloodstream infection 40 hours in advance, don't you think that can make a big change for that patient? So what is the clinical impact? Well, rapid phenotypic AST significantly reduce time to actionable result and can improve antimicrobial decision making. You actually have the full susceptibility profile of the organism. The action depends on the effective implementation, workflow integration, clinical response, and collaboration with the antimicrobial stewardship team. So that is another aspect. If you don't have this communication and this action, that you actually losing a lot of the potential of the utility for this diagnostic. The BCID or the rapid PCR have no definitive proven mortality benefits. Observational studies suggest improvement in antimicrobial use and hospital length of stay. So when in our institution, how we are planning to use rapid AST? Enterobacterales with resistant gene detected? No. We have a good defined plan. We have a good understanding of epidemiology. We have a good profile for each organism based on resistant genes. And rapid PCR can actually drive treatment escalation. Enterobacterales with no resistant gene detected. That's the best target for us. Being able to rapid phenotypic AST can facilitate the escalation by providing susceptibility to basic penicillins with inhibitor quinolones and even trimethoprim sulfate for do PO conversion as soon as possible. But in the non-fermenter group, yes, all non-fermenters will be used directly the rapid AST because we know that it's a Pseudomonas or it's a Enterobacter. We know that the rapid diagnostic or the PCR are not reliable in detecting some of the resistant mechanisms they have. So the primary goal is for the escalation and narrow spectrum beta-lactamase, a PO conversion. If you don't have access to BCID, the rapid AST can actually cover the entire spectrum of the organism. You will have phenotypic data for escalation and de-escalation. But if you have the BCID, you can use the BCID beyond only the organism identification. And this is how they look for us. So we have a gram-negative that is identified as an E. coli. There is no gene detected. We have a 3% chance that E. coli is not a CTXM. And we know that it could not be a CTXM because we have evaluated and see that some of the other genes, SHB, OXA, are present. So when we have this E. coli, we set up the phenotypic AST. So the trigger is an Enterobacterales with no resistant gene. We do a second screening for those 3% ESBL with ceftriaxone and ceftazidime. If it's detected, it's an ESBL, we don't do anything else. But if it's not detected, we are able to release antimicrobials that allow the clinician to de-escalate. Rapid PCR, the BCID, give you the evidence to de-escalate. The narrow spectrum is ceftriaxone, it's third generation. Lower than that, we don't have any evidence that we can continue de-escalating. So now we have the opportunity to go all the way down to penicillin with inhibitors or even agent to provide a PO conversion. The other advantage is, well, in 2024, we have around 1,652 organisms that met this criteria that we will be able to provide rapid AST and have a full susceptibility profile within 10 hours. So what is the takeaway? Conventional method may require 72 hours for identification of bacteria antimicrobial susceptibility profile. The BCID or rapid PCR allow for early optimization antimicrobial therapy for organisms with detected resistant genes, but not all resistant markers are included. Genetic markers are reliable for some bacteria as non-fermenters and do not replace AST, but give you the option to avoid the drug-bot mismatch of almost every single patient that have a highly resistant organism. Traditional phenotypic AST takes several days. So the opportunity with the rapid phenotypic AST is a short time, 7 hours, within 7 hours based on all the platforms that are currently available.
Well, thank you to our faculty and many thanks to you, our listeners. To listen to the other two parts of this podcast or to download the accompanying slides, click on the link in the show notes. Thanks so much, and we'll see you on the next podcast soon.